when you do these procedures to sort of take care of that part of the matter.
Okay, I think in the interest of time, we need to move on to the next session. Thank you all the speakers. Wonderful job. And I think on a Sunday morning, we are having quite a good participation. Roughly 150 delegates across the country are watching. At this juncture, I would like to welcome Dr. Archana Rao. I can see her there. Good morning.
Morning, all.
All good?
Here all good. Thanks, Jay. Thanks for the invitation.
It's all, we are in the third cyclonic storm in south of India, and we're just trying to recover. And everything is now virtual here for us. I think without wasting much time, let's get going. John, I think, can present his first talk, and I'm sure with Dr. Archana there, we'll have loads of questions for her. And I'm sure that she'll be more than happy to take up the questions towards the end. Thank you. Let's go on to John's first presentation.
A very good morning to you. At the outset, I would like to thank the organizers of TNEPIC and my good friend Dr. Jay Shankar for giving me this opportunity to speak to you on lead extraction, a stepwise approach. As you know, lead extraction is a complex procedure fraught with a lot of risk. So at the outset, I'm going to be speaking to you on three broad categories. Firstly, the required infrastructure and support, the simple steps that shouldn't be overlooked, and the mistakes to avoid. So looking at the infrastructure and support required when you plan a lead extraction procedure, it's most important that you have an anesthetist who has experience in performing such procedures, in supporting such procedures. So having somebody with a cardiac anesthesia background would be very useful. It's also very important to have a standby operation theater or a hybrid cath lab available with a thoracic surgeon ready to take the patient in and open up in case there's a complication like a tear in the SVC or a myocardial perforation leading to a tamponade. It's also important to do the procedure under imaging guidance, and a transesophageal echo would be a great asset. Using the same during the procedure with a patient being done under general anesthesia. Having an intra-arterial line is very useful because it helps us quickly pick up drops in blood pressure. It's also good to have blood grouped and typed and cross-matched, and have a bed in the CCU ready for post-procedure care. Now moving to some of the simple steps that should never be overlooked when you do a lead extraction. Firstly, when you open up the site, open up the pocket, take out the pulse generator, separate the pulse generator from the lead, the first instinct that people have is to start tugging on the lead to see if it comes off easily. There is a good chance that leads which are associated with infection would come out. However, it is very important to push the stylet in before you do manual traction. Because sometimes if you give in traction, there's a good chance that you may separate the distal electrode from the lead and lead to unraveling, which is something you don't want to happen. So always remember to put in your stylet before you do your lead extraction. The other important thing is to not give more traction than required, and that's something that comes with experience. It's always good to just give enough traction to tug the lead, but not too much as to causing unraveling of the lead. And it's important to be able to recognize the possibility of unraveling under fluoroscopy so that you don't reach that point of no return. It's also good at this stage, once you find that there is a tendency to unravel, you're not going to get the lead out, that you stop, take out the stylet and replace it with a lead locking device. It's also important to identify the grommet and remove the grommet before you deploy the lead locking device. So that is particularly of great importance if you have a patient who has got an infected pocket, where if the grommet wasn't removed and not identified, it may tend to slip over the lead and stay back and lead to trouble, or worse, migrate into the vascular system. So you don't want that happening. So always good to identify where the grommet is and remove it. Now, when you do the procedure, it's important to clean the chest And the zone that needs to be cleaned often extends to below the xiphoid, so that in the case of an emergency, you can readily access the pericardial space and do a pericardiocentesis should there be a tamponade. Similarly, also good to clean the lateral part of the thorax so that in the case of an emergency, a chest tube can be placed. Now, when you do the procedure, it's important to infiltrate local anesthetic in line with the leads that one wants to extract. So here is the video that shows local anesthetic being given in line and then the skin incision being made along the same line. It's so important to make the skin incision coaxial to the leads so that when you give your manual traction, you derive the maximum mechanical advantage. So this is just highlighting the point I just mentioned. You see the coaxial traction that's being delivered over here. The traction that is being given helps the operator to tug at the lead and thereby deliver the maximum advantage by pulling in the direction in which the lead has gone in. Then it's important thereafter to unscrew a screw-in lead rather than start tugging straight away. So always remember to unscrew the lead before you tug it. And then after you unscrew and make sure that the lead has sort of gone in completely, then the next step is to cut the lead. And when you cut the lead, you need to cut it clean so that you have a nice circumferential opening through which you need to send in your stylet. So that's a clean cut rather than a jagged cut, because if you have a jagged cut, then it's hard to send your lead locking device through the lumen. Once that is done, then you send in the lead locking device. And as you can see here from this cartoon, you can see the lead locking device over there. The lead locking device needs to be sent so that it tracks all the way down to the very tip of the lead. So you can see here the lead locking device being sent. And it's most important to send it right through till it reaches the very tip of the lead. So that is something to keep in mind. Send your lead locking device to the very, very end. Only then is it going to grab the distal portion of the lead and help you with extracting the entire lead in total. Now, with regards to deploying the lead locking device, as you are familiar with, you just push this thing forwards, and once you do that, the lead locking device is deployed. It would help to sort of maintain a forward pressure to prevent the backing out of the lead locking device. Once that is done, once the lead locking device has been deployed, one needs to take ties over the insulation. It's good to take 2 or 3 ties over the insulation so that the entire lead and its insulation is one single unit and helps you when you give traction. So this is just a video that quickly shows you how you take the tie over the insulation and secure it to the other end of the lead locking device. Once that is done, you give a coaxial tug, which is sort of what I mentioned earlier. You can see here that the tug is being given exactly in the direction in which the lead goes in, and that was because the skin incision was made exactly in that direction. After this tug is done, it's important to use the slide rail to create room for the tight rail. So don't jump into using the tight rail. First, use the slide rail, move it in, take it all the way in over the lead into the vein. So that way you made adequate boring through the subcutaneous tissue. And once when you're doing this, watch the fluoroscopy so that you can actually see how your slide rail is going in and make sure that the sharp edge doesn't cut through or shear through the vessel wall. So once you've created enough room for the tight rail, then is when you have to consider taking the tight rail. So while you take the slide rail, it's very important to make sure that the slide rail is coaxial over the lead so that it doesn't go through the lead or go through the vessel wall and lead to a shear in the vessel wall. So this is just a video that shows you the importance of keeping your slide rail coaxial as you move it forwards over the lead. Now, once that is done and the ground is prepared, now it's ready for you to take in the tight rail, and you can move your tight rail steadily over the room that has been created by the slide rail. So this is just showing you taking the tight rail over the lead. This is a dual coil ICD lead, which was in situ for over 10 years. Now, again, make sure that you're using fluoroscopy to see how your tight rail is going. Try to mechanically move it with progressive screwing, unscrewing movements over the lead. And once you do that, then give controlled traction on the tight rail as you negotiate the bend. Now, this is very, very important. When you negotiate the bend, the amount of traction given should be controlled. It shouldn't be too much. It shouldn't be too little. It's good to have an experienced hand helping you, giving you the traction as you move the tight rail forward and start deploying the tight rail. So this is just showing the tight rail getting over the proximal part of the ICD coil. And once that has been done, it continues to move forward with you steadily deploying the tight rail, and it gradually chews over the tissue and tends to swallow the lead as it moves down. You should be very careful when you take this bend as you move from the brachiocephalic vein into the SVC so that you don't sort of shear through. So you have to sort of maneuver your tight rail so that it coaxially goes over the lead and moves forwards. Once that is done, and you move past the proximal coil and come close to the distal coil, it's important to avoid any redundancy in the lead. So you have to sort of manipulate with your traction appropriately so that the lead comes into the tight rail and this redundancy is overcome. So here you can see gradually the lead being pulled, the redundancy being overcome, and the tight rail gradually moving forwards to reach the distal coil. So once you get past the redundancy, then you slowly slide your tight rail, deploying it as and when necessary to get over the distal coil of the ICD lead. Now, the most important step in a lead extraction is when you reach the very end, and that's when you should be very, very conscious not to deploy the tight rail at the end. Because if you deploy the tight rail at the tip of the lead, there's a very high chance that you will perforate the ventricle, and that will lead to a tamponade, and that's going to lead to an ugly tear, which will immediately need surgery to save the life of the patient. So it's just continuous traction and counter traction, no tight rail deployment at the very end, and wait patiently. So you wait patiently, let the patient's own cardiac movement plus your traction and counter traction. You're moving forwards with your tight rail, pulling backwards on the lead, and then the cardiac movement itself helps you pull the lead back, and the lead is safely inside the tight rail now with no complication having happened. The important point to remember is not to deploy the tight rail at the very end. So it's important to learn from the mistakes that those who have done procedures like this before have had, and there are some mistakes that I would like to take that we've made, and I would like you to sort of learn from. So the first thing being, don't let the lead locking device back up when you're giving traction as you pull the lead. So make sure that the lead locking device doesn't back up. Keep a constant eye on how the tip of the lead locking device is, and it should be at the very end of the lead. Next important point was to create enough room with the slide rail before you take in the tight rail. So don't take in the tight rail straight off. Make the path clear with the slide rail before you take the tight rail. And most importantly, as you negotiate the bends, like brachiocephalic into SVC, make sure that you have your tight rail coaxial with the lead. So here are some videos of mistakes that were made, and you can look at this. The lead locking device, as you can see, is sort of backing out. You don't want the lead, you want the lead locking device to be at the very tip of the lead, not to come back. But here you can see that too much of traction has been given. The lead locking device is backed out, and you're trying to negotiate and move this tight rail forwards, and it gradually manages to sort of swallow the lead, which was very, very lucky for us. But you know, once you sort of, your lead locking device is backed up, it does not give you the support that you need to get your tight rail all the way to the tip. So that's something to be very conscious about. Here is another situation where the lead locking device is backed out when you're trying to pull out the ventricular lead, and you take the tight rail down. Now remember what I said, you should not deploy the tight rail at the very end. So here the operator has sort of taken the tight rail down to the very end, and there's traction, counter traction going on. He should just wait patiently, not deploy the tight rail, but lack of patience has led to the operator deploying the tight rail, which actually results in the lead getting cut and a small remnant, the distal electrode, being left behind. Now, this would be very bad if the patient actually had an infection. But fortunately, this was just a lead malfunction, and so the tip being left behind was of no significant consequence. But it's very important not to deploy the tight rail at the very end, because if you deploy the tight rail, you would either end up with this complication, with the part of the lead being left behind, or worse, you could have a perforation. Here is a very sharp angulation, as you can see. And when you do right-sided lead extractions, that is something to be very conscious about. because the angulation is not normal, it's not physiological. You sort of come in from the right subclavian and then get into the brachiocephalic, and it's sort of a right angle. So this sharp angulation needs very, very skilled maneuvering of the titrail over the lead. Make sure that you don't lead to complications. Over here, as you can see in this video, basically there was inadequate traction being given. The titrail was not properly maneuvered over the lead. So it tended to chew into the lead, leading to a shear in the insulation. And this was not noticed by the operator. He continued to deploy the titrail, continued to move forward, leading to more and more of the lead insulation being sheared off. And this is a complication that you don't want to happen. It's important to sort of get your titrail over the lead properly and not like this, where you can see a large part of the lead is sort of sheared off from the way it should normally have been. So this is another situation where the lead locking device, there was too much of traction given, leading to a fracture of the lead locking device. As a result, there was a part of the lead that was left behind, requiring us to use a snare to sort of get over the lead and to pull it down. So make sure that the amount of traction given is appropriate, not too much, not too little. The previous example was too little traction leading to the shearing of the lead. Here you have too much of traction leading to a fracture and the lead locking device coming off, and you are ultimately having to use a snare to sort of pull the lead in through a sheet sent in from the femoral vein and to take out the remnants. So in conclusion, it's very important to know the details of the patient. Is it a right-sided implant? Look at the X-ray before. What is it? A dual coil lead, single coil lead? Is it tying lead? Is it a screw-in lead? These are all things, and how long has the lead been in? These are all things that have important bearings when you do the procedure. Also, is there a lot of fibrosis? The vein all completely occluded? That suggests that the lead is also going to be very much stuck in and it's going to be hard to extract. So that will also help you to sort of prognosticate and speak to the patient prior to the procedure. Very important to have appropriate infrastructure and support, a dedicated cardiac anesthetist, and a surgeon on standby is very key when you do these procedures. Follow the stepwise approach like I mentioned. And lastly, and most importantly, is don't forget to pray when you do these procedures, because they are high-risk procedures, and without the Almighty guiding us, there's always a chance that you would run into trouble. Thank you very much for your patient listening. And if there are any questions, I'm happy to take the same.
Thanks, John. We'll move on to the next. We'll have discussion midway through the session. Over to Dr. Hazara's presentation.
Thank you.
Talk will be on leadless pacemaker from micra to micra AV VDD. And we have this micra AV in 2020, and it is very small, very elegant. Initially, we started implanting BVI. Now we are implanting VDD in most of the cases. It has got certain advantages, like you can have this AV synchronic. We have other leadless pacemaker too. And this is for ICD. This is from Boston. For the Medtronic house, this micra came in 2016. It's very small, 1.75 gram, 0.8 ml, and it lasts for 11 to 12 years. We have initial experience of this pacemaker, even in a young girl, and she is from Pune, Chipmar, and she's a 9-year-old girl, 24 kg. Sometimes you have to go through the internal jugular or iliac vein cut down if you really want to put this 27 French micra device. Now, the large bore femoral vein device, whether it is mitral clip, Pascal system, mitral angioplasty, TM here, LA closer, micra 27 French, angiovac system, ECMO, tandem heart, you have to have a clean venous puncture so that there is no overlying arterial branch lying on the left or right side. The right is always preferred. Left femoral vein and jugular vein, when you have entered the vein, you give full dose heparin or bivalirudin in some cases. Low and medial, enter with 6 French, and once you enter, keep the wire, withdraw the sheath again to see if there is a spot or not. If you see any spot, you have to repuncture. If you have right-sided pacing, better to shift from right to left. And once you've entered, you have to exit. And most of the time in our hospital, This is manual. You can use ProGlide figure of 8 fisherman stitch in addition to your manual compression. It's better to stop NOAC for at least 12 to 24 hours. 1.5 to 1.8 INR on oral anticoagulant is good enough. Now you have to understand that it senses the phonochoreographically the A4 segment of atrial contraction. So if there is no A4 or A wave, obviously this is not going to work. So it's best suited for complete heart block. You have plenty of P wave, nice P wave, and you have AV block. Now, once you put this micra, instantly you can see that it is tracking. There is an algorithm which takes time to be activated, around 2 to 4 hours, and it can automatically detect the best axis, and the P wave sensitivity will be determined accordingly. Now, this senses the atrial sound, kind of sound, and it is quite far away from the atrium. So if there is any device in the atrium or a lead in the atrium, that can interfere with the AV synchrony. So preferably we remove any redundant lead in the atrium once you're upgrading. Now this micra, like any other device from the femoral vein, like BMB, we start with ampular wire, and this goes to the vein, either left or right, doesn't matter. It's not that important. Now, once you have a difficulty in the femoral vein, you'll get a resistance in the iliac with the inguinal ligament is the toughest one. So once you cross the inguinal ligament, this ring will traverse upward, and you can do it under fluoroscopy. If you have difficulty in accessing the vein, you can use a body wear, you can dilate, and most of the time it is very easy. Pre-dilatation is important in some cases, but not always important, because in thin elderly people, you can go with the microdilator directly into the right atrium. So dilatation or no dilatation, it to reach because it has a special coating. If you have a filter, there is a problem. If you have interrupted IVC, jugular, or there are some reports of going femoral vein, going through the femoral vein, even in interrupted IVC. So basically, it is a fall from above, and once you reach the top with your prepared device, you see there is a ring, black ring, and you remove the wire and the dilator, everything. You keep the temporary wire as a piggybacking, and you should remove or pull down the sheath. The ring should be below the hepatic vein as far as possible, and then you dive back into the RV apex on your AP view or RA view. Now, if you have any resistance, do not push it forward, rather to move back. And there are certain movements like clockwise, anti-clockwise, up and down. And once you're happy, you can give a small injection to see your destinations. That can be done either through a multi-purpose before taking micra, or even through the sheath of micra, it can be taken. There is always a chance of your temporary pacemaker get displaced, pull back. So you have to be very careful, and most of the time it is quite stable. So once you are happy with that, and you are actually happy with the threshold, you can cut the thread and your job is done. Now, reaching apex, there are 6 movements, as I said: clock, anti-clock, flex, anti-flex, up and down, piggybacking, RO, LO, and always look for the kinking of the device. So if there is a resistance, you should not push it further, because if you kink, the whole mechanism will not work. So what you have to do, you have to remove the micra, give a massage, and continuous flushing of side 4Ds to prevent the clot. Thus, the threshold or the tip of the micra is good. Now this piggyback, as I said, at the lighthouse of the heart, where you know that the left margin is inferior and you have temporal pacemaker. The right-hand margin is your apex, valvular part of the septum. So you know your destinations. As I said, the multi-purpose sometimes can be done, but if you have a raised creatinine, this is a problem. Once you are releasing the micra, you know how to release it. Keep the cup inside the RV so that the recapture is possible. And if you are not able to realign for recapturing the micra for better threshold, sometimes you have to pull the whole micro system into the RA, then reload it and go again. Lower septum at 90° to IVS on LAO or apical view on RO is a preferred one, but wherever it goes in first chance, you should take it. Less chance of pericardial effusion if you go inferior, and if you are happy, then you go for 50 frame per second double zoom collimation for hooks. And if you have 2 or more hooks like this, then you are happy. Now, in this upgradation from a single chamber to a double chamber for heart failure, and this cannot be differentiated by visual impression, which one is micra AV or which one is plain micra. But they can lie parallelly without any interference. So on your other views, you confirm that is lying nicely, then you cut the tether. Now you have to understand certain parameters like any other pacemaker, is oversensing of A4, threshold, that there are certain things you must understand. And this computer automatically programs this micro AV up to your need. And once you have this pacemaker, after the explantation of the infected pacemaker on this gentleman, he can walk, you can recheck their AV synchrony, coughing, Valsalva, walking, and it is almost immediate in most of the cases. Device positioning, as I said, you have to make a swan necking, and this push will automatically take this micra deep inside the RV apex, and it starts working immediately. So for recapturing or checking the fixation, you just pull the thread. The cup will move towards the micra rather than micra moving towards the cup. So repeatedly you can check it, you can check the threshold, and your job is done. So for recapturing, pull the string, align and cup to the pin, confirm in 2 views, lock the tether again, reload the micra in the sheath, start all over again. Tuck test, rechoke threshold, usually it is 0.2 or 0.3, less than 0.5 in 90% of cases. Do not accept anything more than 1.5. And it is better to check in 2 views for the recapturing of the device, for the alignment of the device. If you do not have this alignment, your micra can get damaged. So better to come back to the RA and pull back the whole device and reload it. As I said, post CEBG or no CEBG, but if you have a transplanted heart, it's a little bit difficult. So permanent pacemaker in transplanted heart, I have only one experience. This is around 5 to 10% post-TAVR, and you have infected lead, you can extract the lead, then you can go for this kind of implantations. You can wait for 24 hours, but most of the time it is very, very effective. Now, dateless atrial kind of CRT is possible from this one particular company, Biotronic, because of this VDD, and it senses the atria. So it's kind of atrial leadless pacemaker for his bundle pacing. You can also do the concomitant AV nodal ablations and through another, say, 14 French sheath through 27 French Medtronic sheath for ablations. So these concomitant procedures are possible through the ring, tricuspid ring, a TAVR, heart transplants. And we also look for other things in the future that if it is transient, if you can increase or bring back the sinus rhythm, like your cardioneuro ablations of the certain plexus, you may not need the full support of this pacemaker in the future. So bringing the sinus rhythm from AV block or sinus node dysfunctions, withdrawing the parasympathetic is a reality now. Repeated lead endocarditis, post-TAVR, post-mechanical, post-PCI, pocket infection, these are the usual indications. So in future, we'll be having a biological pacemaker, bi-absorbable pacemaker. And with that, I would like to summarize then micro pacemaker, AV or BVI is very simple to implant. I do not have any complications so far. Acute rise of threshold is not there. And it needs a very small learning curve. It is done under heparin. Entry and exit is not an issue like atrial system. You fall from above, see better on your X-ray for anchoring, and threshold as low as possible can give rise to long-term extended life of this pacemaker. With that, I'd like to thank you for your kind attention.
Thank you, Dr. Hazra. I think we should move on to Dr. Anil Saxena's talk on the subcutaneous ICD. Please start displaying his slides.
Good morning, friends. I would like to begin by thanking Tamil Nadu Electrophysiology Council for inviting me to this session. It's truly an honor. Over the next 15 minutes, I will discuss the subcutaneous ICD and how it compares with the conventional transvenous ICD. It's a long subject and I will try to be as concise as possible. So we know that ICD is a very important therapy to prevent sudden cardiac death in patients susceptible to malignant cardiac arrhythmia. However, the conventional transvenous ICD have certain problems. Almost all the complications of ICD, whether they are acute like hemopericardium or pneumothorax, or chronic complications like lead failure, endocarditis, venous occlusion, or issues of lead extraction, they are all because we have to place a lead inside the heart. And as the right panel shows, there are numerous studies showing significant complication rate related to ICD leads. The incidence may be as high as 10 to 20% over 10 years. This slide shows a study done on about 2,000 ICD patients, and there was a 16% lead failure rate at 10 years. The important thing here is that lead failure was distributed among all the major manufacturers, so it appears to be a problem of all the ICD leads. There may be some minor variation, but every ICD lead is susceptible to failure. And this failure includes a high threshold. So there has been a talk about developing an entirely subcutaneous ICD for a long time, which would be totally outside the thoracic cage. Dr. Badi et al. Led the development of subcutaneous ICD and published his first paper in 2010. This study shows effectiveness of entirely subcutaneous ICD for the first time. And the lowest DFT of 32 joules was achieved by a configuration where the device was placed in the hollow of axilla and defibrillation coil was in the parasternal area, as shown in the panel A. Now, the subcutaneous ICD has certain advantages, potential advantages. There is no need of venous access, and for the same reason, it avoids lead endocarditis and also the problems associated with the lead extraction. It may be better suited in younger patients because we can preserve the site for transvenous ICD for a long time. However, there are certain disadvantages that there is no bradycardia support, pacing support, there is no anti-tachycardia pacing, and the device cannot be upgraded to CRT-D. So that is how the device looks. The can is placed in the hollow of axilla, and the coil is in the parasternal area. The lead is tunneled along the subcostal margin. There are two sensing electrodes on either side of defibrillation coil. There is a proximal and there is a distal sensing electrode. The primary vector, sensing vector, is between the proximal coil and the can. The secondary vector is between distal coil, distal electrode and the can. And between the two sensing electrode, there is an alternate vector. The important point here is that all patients are not suitable for subcutaneous ICD. So we have to do a screening of surface ECG before patient can be accepted for subcutaneous ICD. This was initially done by using a plastic scale-like tool available, but now it is automatically using in an automated fashion using a programmer. So all patients are not suitable for device, because certain patients may have a very tall T wave and that may lead to double counting. So we have to have certain QRS configuration and T wave. There are certain limits to QRS and T wave. Patients, usually what we have seen is that about 8 to 10% patients may be rejected based on the surface ECG, and this percentage may be higher in patients with hypertrophic cardiomyopathy. The most frequent cause is a very tall T wave or very tall or deep T wave. The device delivers a 80 joule fixed non-programmable biphasic shock. The charge time is about 10 seconds or less, and there is 30-second post-shock pacing, which is basically high energy pacing through the chest wall. And of course, there is full-featured episode storage. Time may not permit me to describe the implantation process in detail, but briefly speaking, the device is placed between the latissimus dorsi and the serratus anterior. So and of course, it should be placed as posterior as possible, as we can see. So it's always good to make surface markings before we do the procedure. And we can feel the belly of latissimus dorsi and try to place the device behind the latissimus dorsi as much as possible between the two muscles. So that's how the device looks on chest X-ray. It's important to note that there should be minimum tissue between the device and the thoracic cage, between the can and the cage. And similarly, there should be minimum tissue between the sternum and the defibrillation coil. So in fact, a score has been designed called Praetorian score based on these 3 parameters. And points are given for thickness of tissue between the defibrillation coil and the sternum. And also, secondly, for the position of device as in relation to the mid-axillary line. And lastly, based on the amount of tissue between the device can and thoracic wall. And a low score is associated with a lower risk of conversion failure. So the SICD has a very simple working algorithm. First, there is a detection phase in which the cardiac signal is collected. In the certification phase, the device eliminates non-cardiac signals and ensures accurate heart rate. And the last phase, there is it's called decision phase, where it analyzes the HR heart rate to decide about the tachycardia and applies insight algorithm for SVT discrimination if it is required. The device delivers up to 5 shocks per episode at a fixed output of 80 joules. There is up to 128 seconds of ECG storage per episode, and up to 44 episodes can be stored. So as I said earlier, there is post-shock pacing, which is basically high energy transthoracic pacing consisting of 200 MA pulses, and it can be delivered for up to 30 seconds. The device programming is quite simple. It can be switched on and off. The post-shock pacing can be switched on and off. It is possible to program a conditional zone for SVT discrimination and set the upper limit of conditional zone beyond which the device will not apply any SVT algorithms and will deliver a shock directly. A meta-analysis was published in 2017 by Indranil Basure. It showed that the lead-related complications were very low in SICD, and that's the primary premise on which the SICD was developed. The system failure rates were quite similar. The infection rates are also quite similar. In fact, the inappropriate therapy was also quite similar in this particular meta-analysis. But the reason for inappropriate therapy was different. The subcutaneous ICD was better in SVT discrimination, while the transvenous ICD were superior in T-wave oversensing detection. The Praetorian trial was the first head-to-head comparison between subcutaneous and transvenous ICDs. So about 850 patients were randomized to SICD or transvenous ICD and followed up to 48 months. The primary endpoint was a composite of complications and inappropriate shock incidence. And the secondary endpoints were device-related complications, lead-related complications, inappropriate shocks, cause of inappropriate shock, and mortality. So over a follow-up period of 4 to 5 years, there was no difference in the primary endpoint of complications or inappropriate shock incidence. Similarly, the all-cause mortality was similar in both the groups. There was slight difference. SICD has slightly higher mortality, but not statistically significant. The device-related complications were less in subcutaneous ICD, but it did not reach statistical significance, and the authors projected or postulated that it would take about 8 years of therapy to achieve significance. So it was the lead-related complication rate where the subcutaneous ICD truly shines and shows significant superiority over transvenous ICD. And this was quite expected because this is the premise on which this device was developed. And as we can see that in the transvenous ICD arm, there were 4 times as many complications or lead-related complications as in the SICD arm. So there was a marked difference between the two groups. The inappropriate shock rate was quite similar in subcutaneous ICD and transvenous ICD group. So the Praetorian trial concluded that subcutaneous ICD was non-inferior to transvenous ICD with respect to cumulative incidence of primary endpoints of device-related complications or inappropriate shock. And as we can see in this trial also, the cardiac oversensing was more common with SICD, while the SVT discrimination related issues were more, the inappropriate shocks because of SVT were more with transvenous. So we can say that the SVT discrimination is better in SICD, while the T-wave oversensing is better in transvenous ICD, similar to the meta-analysis that I discussed earlier. Now, the other important recent trial is UNTOUCHED trial. In this study, about 1,100 patients were implanted subcutaneous ICD, and they were analyzed for inappropriate shock-free rate. And based on the RIT trial, a performance goal of 91.6% was set. The subcutaneous ICD achieved an inappropriate shock-free rate of 95.9%, which was significantly better than the performance goal of 91.6%. Now, this slide shows the evolution of subcutaneous ICD as far as the inappropriate shock rate is concerned. As we can see in the initial studies, the inappropriate shock rate was quite high, up to 10 or 13%. And then it has progressively declined with the improvement in the algorithms to detect oversensing. And in the latest trial, that is UNTOUCHED trial, we can see that the inappropriate shock rate was only 3.1%. And in fact, it is 2.4% if we include only patients who have been implanted the generation 3 device. So this appears quite comparable to transvenous ICD rates, inappropriate shock rates. So this is where, and the reason for this high rate is that inappropriate shock rate was that the subcutaneous ICD has a very wide sensing window, making it more susceptible to sense extra cardiac signals or even cardiac signals like T-wave, etc. But this has been taken care of by improved algorithm. So the UNTOUCHED trial concluded that subcutaneous ICD is non-inferior to transvenous ICD in incidence of inappropriate shocks in primary prevention population. The latest generation Emblem ICD has a smaller size, better profile. The battery longevity is another big concern with SICD. It used to be around 5-6 years. Now it is about 7 to 8 years. The device is MR conditional and it has remote patient management enabled. So what do the guidelines say? The 2015 European Society guidelines assign a class 2A to SICD in patients with an indication for ICD when pacing therapy or CRT or anti-tachycardia pacing is not required. So it's reasonable to consider SICD in that population. The 2017 ACC-AHA guidelines mention that subcutaneous ICD is a class 1 indication if the patient meets criteria for ICD but has inadequate vascular access or a high risk of infection. And of course, there should not be any requirement for pacing or CRT or ATP. And in other patients, like routine implantation of single chamber ICD, we can consider either of them. It's a 2A indication to consider subcutaneous ICD in that population. So what do we look forward to in future from subcutaneous ICD? Of course, we want a further reduction in device size, which is still bigger than the transvenous ICD. The longevity can certainly be improved and brought as close to transvenous ICD as possible. We expect better programmability and more diagnostics. And of course, there is a possibility of ATP or pacing support through the leadless pacemaker. So it's not a fantasy. The work is already going on, and industry is developing. They're developing a pacemaker called Empower, which will work with SICD and deliver pulses wherever required. And that's a published report of ATP being delivered through the subcutaneous ICD utilizing a leadless pacemaker. So what is the take-home message? So I would say that the SICD should be considered or sometimes even preferred in patients who have venous access issues, patients who are on hemodialysis or are immunocompromised for some other reason, patients with the channelopathies and hypertrophic cardiomyopathy, where anti-tachycardia pacing is not required usually. Besides, patients with previous device infection or younger patients can be good candidates for subcutaneous ICD and can be considered in women for cosmetic reasons. On the other hand, patients with white QRS who need or may need in future a CRT requirement, they should not be given subcutaneous ICD. And it should be avoided in patients who have bradycardia who may require pacemaker support in future, or patients with sustained monomorphic ventricular tachycardia for whom ATP is considered necessary. I think I will stop here. Thank you for listening.
Thank you very much, sir, for your elegant presentation. And now I would like to invite Dr. Archana Rao, who is one of the high volume implanters, device of all kinds, lead extractions of all kinds. And I'm sure we'll have quite a few questions for her. And she's going to first talk on improving heart failure non-responder rates by reprogramming, by appropriate programming of the device. Welcome, Dr. Archana, and over to her presentation, please.
Me to speak on how to improve heart failure non-response rates with device programming. I've taken the liberty of changing the title slightly to CRT non-response rates because I presume that's what you're referring to. I'm Archie Rao, a consultant cardiologist at the Liverpool Heart and Chest Hospital. I'm a heart failure specialist who performs a lot of complex cardiac devices, lead extractions, CRTs, and follow-ups. And I have extensive experience in CRT implantation and follow-up. When we talk about CRT response rates, we really need to understand what is it that we're talking about. I think there's echocardiographic response and there's clinical response, and they don't mean the same thing. Echocardiographic response has traditionally meant reduction in end systolic volumes, improvement in ejection fractions, and clinical response has generally meant reduction in hospitalization, improvement in outcome measures such as 6-minute walk test, quality of life, and indeed life expectancy. As a ballpark figure, response rates are between 60 and 70% for echocardiographic response and between 70 and 80% for clinical response. That said, the correlation between clinical and echocardiographic response is not quite as one might expect. So if you look at the pie chart on your left, in those patients who were clinical responders, over a quarter did not demonstrate echo response. And vice versa, in those patients who were clinical non-responders, 1/5 of them demonstrated echo response. You can thus see that even as we define response, there is significant confusion in what constitutes response. The most recent CRT trials, such as the MADIT CRT, have moved away from echo response and are much more concentrating on a clinical response, predominantly defined as improvement in quality of life, improvement in outcome measures such as heart failure, hospitalization, and mortality. I hark back to this paper from Mullins, which looked at the prime causes of non-responders in patients with CRTs in situ. And the big one in his experience was suboptimal AV timing. There was arrhythmias. There was, of course, anemia, suboptimal LV lead position, which we'll touch upon, the delivery of CRT, which is very, very important, suboptimal medical therapy, and then poor selection. Clearly, when you implant a CRT, it's really important to select the patients who are most likely to benefit from a CRT. And those patients are patients in sinus rhythm with poor ejection fractions and broad left bundle branch complexes. Okay, a minimum QRS width of 130 is recommended, and preferably 150 with a left bundle branch morphology. So when we talk about suboptimal AV delay, obviously the AV delay is the time between your atrial delivery and your ventricular delivery on a pacing system. When that AV delay is too long, i.e. the programmed AV delay is greater than the intrinsic PR interval, there is failure of CRT to be delivered. Ventricular sense episodes happen because intrinsic conduction is happening, inhibiting the delivery of the CRT. There's also possibility of fusion and pseudofusion, just thus resulting in ineffective CRT. When this does happen, it does impact on battery longevity without any potential gains for the patient. Of course, if the AV delay is too short, there's inadequate diastolic filling, i.e. there's mitral valve closure even as atrial contractility is occurring, and this is quite obvious on the mitral flow Doppler. So on this Doppler assessment, you can see what constitutes a satisfactory AV delay. This is simply a mitral pulse flow Doppler across the mitral valve. You can see the E wave and the A wave, and the A wave represents atrial contraction, i.e. the last active phase of diastole. When that finishes, the mitral valve closes, and this is really important because if the mitral valve were to close early on, the atrial contraction is lost amidst the ventricular contraction, thereby reducing preload and therefore afterload and thus stroke volume. So this is a key factor in deciding what the true AV delay should be. Modern devices have gotten cleverer and cleverer, and certainly there are some devices that actually deliver on your quick look screen what is an effective CRT. An effective CRT is very much measured from LV cathode to RV coil. And as we traditionally do, it looks at the negative deflection and decides if depolarization is actually happening and true capture of the LV myocardium is being achieved by the coronary sinus lead. And this in turn would let us know if we've got what is classed as biventricular pacing, but actually pseudofusion, or do we have biventricular pacing, which is actually effectively delivering CRT. We could use this diagnostic on the devices to decide if our AV optimization is truly right or not, the timing of our AV is truly right. We then move on to arrhythmias, and clearly arrhythmias contribute to inadequate biventricular pacing. Atrial fibrillation is the big one, as demonstrated on this cardiac compass screen. You have episodes of atrial fibrillation, which then result in rapid ventricular conduction or intrinsic conduction, loss of AV synchrony, and loss of CRT. The other big arrhythmia faced by the heart failure population is ventricular arrhythmias, either slow VT or ventricular ectopics that reduce the delivery of effective CRT. These, of course, need to be handled with adequate use of beta blockers and modern heart failure medication that includes things like sacubitril valsartan and SGLT2 inhibitors. When we look at the latitude registry of 4, we realize in almost 40,000 patients, a cross-sectional observational longitudinal cohort, we notice that when patients get maximum CRT, their outcomes are much better. And when you have CRT delivery less than 95%, the outcomes are much worse. So how much CRT is enough? Well, ideally, you want as close to 100% as possible. And that's obvious from many, many, many studies. So much so that when you talk about the new era guidelines for CRT with persistent atrial fibrillation, it's very much recommended that AV node ablation be added in case of incomplete biventricular pacing. And they've defined incomplete or inadequate biventricular pacing as less than 90 to 95%. So when you see a patient with this, you need to optimize beta blockers, you need to consider amiodarone, you need to consider a cardioversion or a PVI. And if all these measures fail, you need to consider an AV node ablation. We talk about LV lead position. We know from the MADIT study, the MADIT CRT study, that patients who had apical leads did less well than those patients who got non-apical leads. This is very much a thing to be looked at the time of implant in RAO, and you ideally want to be basal or mid rather than apical wherever possible. Modern day quadrupolar leads have made this very possible with use of proximal poles if you should be unable to find a steady mid-polar position. There's, of course, the electrical positioning of the leads, and the electrical positioning of the leads was demonstrated in the SMART AV study, which looked at a figure called the QLV, which looks at the time of sensing between the RV and the LV, and came up with a magic number of 95 milliseconds, where over 95 milliseconds suggested that the patients did better. And this is simply the electrical timing between the RV and the LV. So very much that gap between RV sensing and LV sensing, and placement of the LV lead as far lateral as possible so as to get good synchronization of a dysynchronous ventricle. We then had the target study, which followed close on its heels, and the target study quite suitably demonstrated that avoidance of scar was a good idea at the time of implant. If you do know that there are areas of scar, then it's a good idea to avoid them because the patients did better where the LV lead was placed, where there was no scar. They also talked about concordant, adjacent, and remote positioning of the leads based on speckle tracking for areas of latest dyssynchrony, and to try and target those areas wherever possible at the time of implant. There is, of course, a surface ECG evaluation of biventricular capture. And for those of you who follow up CRT patients in your clinics, I would strongly recommend a 12-lead ECG looking at capture. So ideally, V1 should have RS ratios greater than 1, i.e. a right bundle type pattern. If not, you look at lead 1, which is your lateral lead, and you should really have RS ratios less than 1, i.e. queued out complexes suggesting depolarization happening from the left ventricle towards the right ventricle. If neither of these parameters are true, you would strongly recommend that you have a look at your parameters and see where your LV lead is. And this would be one example of it. So when you're assessing CRT delivery, what are the sort of things you're looking at? You're looking at pacing frequency. As mentioned, you want the pacing frequency of CRT to be as close to 100% as possible. We know from historic studies that when CRT was not being delivered, even on a beat-by-beat basis, the benefit of CRT was lost. So it's a very mechanical thing. Synchrony only happens when LV pacing is happening. If you lose that LV pacing, you lose that synchrony, and therefore you fall back to left bundle branch block, presystolic MR, and dyssynchrony. Ideally, this figure says 90%. I would go as far as to say 95%. The ERA guidelines say somewhere in the middle between 90 and 95%. If you are having ventricular frequency pacing of greater than 90-95%, what you need to absolutely ensure is LV pacing capture present. And this goes back to what we were talking about earlier, effective pacing. Are you getting effective left ventricular capture? If not, reprogram your left ventricular pacing vector, get a 12-lead ECG, and ensure that CRT is delivered. If there's no capture, increase your pacing output. And if that's still not happening, you need to really understand why that is the case. With electronic programming, you could run various parameters. You could run Vector Express. You could get 12-lead ECGs. You could evaluate the pacing in an appropriate manner so as to ensure that adequate CRT capture is happening. If all of this is not happening, then I'm afraid you have no option but to reposition the lead. What happens if your device is telling you that the patient is having infrequent biventricular pacing, i.e. less than 90% or less than 95%? So you're obviously getting ventricular sensing happening rather than biventricular pacing. And as mentioned, the classic algorithms would be shorten your AV delay. You use your CRT algorithms, and every CRT has its earmarked algorithms. On the Medtronic devices, turn effective CRT on so you know what's going on. What proportion of your CRT delivery is effective? Consider AV node slowing drugs. And if the patient's in AF and having rapidly conducted AF, consider an AV node ablation. If the cause for the ventricular sensing is not related to conducted atrial rhythm, consider frequent PVCs, ventricular ectopics, non-sustained VT, or slow VT. And if you're getting frequent ventricular ectopics, consider a 24-hour Holter monitor. to see if these ectopics are monomorphic, because if they are, they might be amenable to a VT ablation. If not, again, consider turning on specific CRT algorithms specific to your device, and that might be things like so as to reduce the atrial refractory episodes post-ventricular ectopics. It might be to do taking the base rate up. It might be to improve your beta blockers and consider further antiarrhythmic drugs for suppression of ventricular ectopy. So CRT pacing programming, you will go through this in a little bit of detail because this is an important slide. The goal of CRT pacing is to achieve 100% biventricular pacing, so at least 95%. Now, in order to do this, you need to ensure that your LV lead placed has a decent threshold, and that threshold is not too close to twitch threshold. Because if you accept high thresholds, and the patient then has twitch at lower thresholds, then there's going to be a problem because you're not going to be able to pace with an adequate safety margin. We know from historic studies that the safety margin varies by almost 50% depending on the threshold. As an illustration, if a patient has a threshold of 2 volts, then his capture threshold might vary between 1 volt and 3.5 volts. And therefore, you really should aim to get a decent threshold with an adequate phrenic nerve capture margin at the time of implant. That said, the nominal settings on most CRT devices is a DDD pacing mode. Turn the rate response on only if there is evidence of chronotropic incompetence, because most of these patients have adequate sinus node function and they do not require a rate response on. So often we would leave them with a low base rate, ascent biventricular pacing. There's no added advantage of atrial pacing in this cohort. You turn on the atrial sensor, the upper sensor rate at 120, upper tracking rate 130. If you have a young NYHA class 1-2 patient, then you might consider extending the upper tracking rate. The mode switch is always left nominally on the Medtronic devices or whichever devices have this available. Turn capture management on wherever possible, because that will allow for adequate CRT delivery, even if the threshold was to rise slightly. Your sensed and paced AV delays should be nominally set at 100 and 130, or at least a sensed plus 30 to 50 milliseconds. Unless you're doing more to it, rate adaptive AV is always on, and the post-ventricular atrial refractory period is an auto or 310 milliseconds. That's my last slide. Thank you.
Thanks, Dr. Archana, and Dr. John and Dr. Archana, you can, take forward the discussion. Just one quick question to Dr. Archana. Do you routinely advocate echo-guided reprogramming, or it's only when there's a non-response?
Thanks, Shay. We've actually moved away from echo-guided programming, partly because the evidence is no longer edging towards that. And the reason for that, of course, as we know, is that in-office programming does not reflect what happens out there for the patient. Particularly, I think with rates, when the patient's at rest, it's all very nice to look at the mitral flow Doppler and time your ventricular contraction to the end of the A wave. But as they move out, they start to do stuff in the real world. I think it's no longer reflective. So we've actually moved away. And as I've mentioned, the algorithms, the dynamic algorithms across the board have gotten better and better, with almost superiority demonstrated over echo programming. But of course, it depends on the version of device that's available geographically, and I accept that. As a standalone, though, for those who haven't got the access to the advanced algorithm devices, I think a mitral flow Doppler is always a good idea. It's a quick test, quick check, and we no longer sit with the VV optimization, but I think the AV optimization is always a good idea to look back at. You're putting in a big device, you certainly want it to be working as well as it possibly could be.
Dr. Anil, sir, you would like to ask? You have to unmute.
Yeah. Thank you. I completely agree with Dr. Rao that echo-guided is, at the moment, it's certainly not useful at all in most of the studies. But that is something we always have been looking forward to, that maybe something will come up, but it has always disappointed us.
John or Shanmugh Sundaram, you have, I think I see you there.
Nothing really to ask right now.
Regarding Dr. John's presentation, Archit, do you advocate the same kind of lead extraction, or you also do some kind of laser and
So, as you know, Jay, we're a very big extraction center, and I do about probably 150 leads a year. So that's considerable in the West, really. We do everything, but I completely agree with everything John said. The key is in the preparation. This is not a game. You take your steps, you take them gently, and you take every case, give it its due merit with respect. Because the bottom line is that you're tugging and you don't really know how much tug is too much tug. And I always tell my trainees, at the time that you do know, it's often too late. You already created damage. So exactly as John said, arterial line, a TOE, we have something that people might find useful. We have a RAG rating, so we have a red, amber, green. In as much that less than 2 years, we're okay to undertake it with relative, we don't have all the faff. The reds are the over 10 years, the previous grafts, the previous stenotomies. We almost always have a designated surgeon available to cover the case, because you have a sweet spot of about between 5 and 7 minutes if you should get an SVC laceration. And nominally having a cardiac surgeon scrubbed in another theater is almost never enough, because femoral access is something we've learned to come by in the complex extraction cases, just so we can get the patient on fem bypass, while things are ongoing to establish repair. But yeah, no, absolutely. We do have a laser, we have snares, we have the tight rail, we have a propylene sheet, but I would strongly suggest using a very stepwise approach. So what John called site rail, we call propylene sheets. So prepare the lead, understand what type of lead it is, lock it, unscrew the lead, always have a go at unscrewing the lead before you tug on it, because often the screw will unscrew, and that's the least traumatic of all. So completely agree with everything John said.
And what are your thoughts on subcutaneous ICDs? Are you a big fan, and do you by those indications what Dr. Anil showed?
Oh, completely. What Dr. Saxena said was everything that we would be doing. And again, we've taken a very measured approach to both subcutaneous ICDs and leadless spacing. I think there is a role for all of these things, but you've got to select your patients rightly and completely. The only other thing I would add to subcutaneous ICDs is it's probably worth, if you have young patients, templating them even on the treadmill, just to ensure that their T waves don't change significantly, because sometimes at rest the T waves are reasonable, but we've noticed that you can get inappropriate therapy when the patient's exercising because the T wave RV morphology changes. But yeah, I mean, it's a good extravascular option for patients who benefit purely from shock devices. And the new SmartPass filter with the new generation devices has substantially decreased the number of inappropriate therapies. So yeah, absolutely. If I may perhaps speak out of turn, I just wanted to add to the leadless spacing thing, just to say that we've completely moved to sonocide-guided, ultrasound-guided femoral punctures. And I think our vascular interventionists are very glad for that. Blind punctures are very good in very experienced hands like ours, perhaps. But as the trainee generation is coming through, the sheets are getting bigger. It's really worth using ultrasound-guided punctures to just be sure that as your wire tracks, it's tracking in the right vein. Because with a 27 French sheet, you don't need much to shear off a small arteriole. And once you've done that, it's not something us as cardiologists can salvage. You're begging for the vascular surgeons and the interventional radiologists, and it's always slightly embarrassing. So that's my only comment on that. So
Can I ask a question to Arshad?
Sure.
Yeah, so about the leadless spacing again. So see, leadless spacing and conduction system pacing, they are contradictory to each other. So do you consider leadless pacing in a patient as a substitute to conventional single chamber pacemaker? Obviously, leadless pacemaker so far have been implanted only in patients in whom VVI pacemaker is required. So do you use them as a substitute to conventional pacemaker, or only in patients with like the niche indication where there is a venous access issue or both pockets are infected? Because on one hand, we are moving towards conduction system pacing to try to give a patient more physiological pacing, and then this lead pacemaker is completely different.
So that's a really good point, Dr. Saxena. And I think I'm very much a very conservative, very measured, aggressive interventionist. So for me, I think you need to really justify why you would use a VVI in a situation where we know that it's non-physiological. And so exactly as you said, for me, I have a large extraction population. I have the hemodialysis population. I have some young patients who very much need backup pacing. So those will be my choices for a leadless pacemaker, where I really hope to gain by saving the vessel either for later or because there are no vascular access issues. I think a standard VVI is cheap, it's effective, it's safe. And I don't see why, a leadless pacemaker should replace that. So I think it is niche. It's far more expensive, and unless there's a good reason, so that you'll get the occasional patient who does contact sport or, doesn't want cosmetically, is refusing to accept. So you will get psychological indications, physical indications, but I'm very measured in my approach to leadless pacing. I think it is a very safe procedure, but it's not without its risks. And I think we'll do well to select patients rightly for it.
Thank you.
I think we should move on. Thanks very much for all the insight, Dr. Archana. I think we go on to our next talk on CS pacing, the conduction system pacing.
Thank you for asking me to speak on conduction system pacing. I'm a consultant cardiologist at the Liverpool Heart and Chest Hospital. I'm a heart failure physician who does complex devices, lead extraction, his bundle pacing, subcutaneous ICDs, and leadless pacing. Over the course of the next 15 minutes or so, I hope to provide you
Salim, good morning, good afternoon, how are you?
The whys, the whats, the hows, and the so whats of bundle branch pacing. When we get back in the story of pacing, we know historically that right ventricular pacing has been detrimental across all groups of patients. Those patients who had single chamber pacemakers for atrial fibrillation did badly when they had high proportion of ventricular pacing. And in terms of outcome measures, it included events like heart failure, hospitalization, and indeed mortality. This included patients in dual chamber pacing, and as little as 40% ventricular pacing was thought to be detrimental when we came to patient outcome measures. This finding extended to the defibrillator population, and we know from the historic David study, which compared dual chamber versus single chamber ICDs, that when patients had no indication for ventricular pacing and had a low ejection fraction of 40%, RV pacing resulted in dysynchrony, and those patients who paced more than 40% had worse outcomes. The quality of life was worse, they developed more heart failure, and were eventually more likely to succumb to heart failure than those who did not RV pace. There were 500 patients included in this study, with comparison between DDDR at 70 beats per minute and VVI at 40 to reduce RV pacing. History has taught us that optimal current programming means reducing ventricular pacing wherever possible. Minimizing ventricular pacing modes have evolved over time, and most of us program our defibrillators to just simply backup pacing. AV and VV synchrony have been sacrificed at the expense of reduced ventricular pacing in patients with prolonged AV delays. There is, of course, the thought that nags most cardiologists: what is the true impact of extending AV delays to non-physiological? Is this possibly pro-arrhythmic? Does that cause presystolic mitral regurgitation? These are the questions that have plagued us even as we've reduced the amount of RV pacing. We then, not surprisingly, explored options of pacing but not right ventricular apical pacing. And the historic trials have been very equivocal. So you can see at the line of no difference right in the middle, most patients did slightly better with non-apical pacing, but not significantly so. As time evolved, of course, what came into the fore was his bundle pacing in lieu of RV pacing. I've shown you the evidence that pacing-induced cardiomyopathy is not a good thing, and as little as 20% ventricular pacing is adequate to have detrimental impact on patient outcome. There have never been randomized controlled trials on his bundle pacing versus RV apical pacing, but there have been significant number of observational studies with over nearly 700 his bundle pacings that have demonstrated improved primary outcomes in terms of heart failure hospitalization, death, or indeed upgrades to biventricular pacing. And the observational cohort data have been robust enough to be incorporated into the new ERA guidelines. So what does physiological pacing entail? Essentially what it entails is us accessing the just distal to the AV node, the His bundle, prior to it joining the left bundle and the right bundle. So accessing the node and therefore recruiting the heart's own physiological conduction system so as to provide the most efficient and efficacious heartbeat that could possibly be provided. How do we target the conduction system? Well, the industry have been partners in this. We have a selected lead called the S3830 lead, or the Select Secure, which is a cable design lead with a 4.1 French diameter, which is catheter delivered to the area in interest, i.e. the conduction system, where it has a deployable screw, a helix that is deployed into the conduction system. It has a polyurethane insulation and a reasonably good extraction data for the future. The implant itself involves the use of a catheter. As I mentioned, the cable design of the lead suggests that we can't use a stellate to direct the lead, and therefore it's very reliant on the catheters to deliver the lead. The catheters primarily involve the C315, which is a 6 French catheter available in 2 different lengths. And this is shown on in the picture on top. It's available in a 30 centimeter length and a 40 centimeter length. The newer catheters are deflectable, and it's the C304 catheters, which is available in 3 different lengths, the 30 centimeters, the 40 centimeters, and the 45 centimeters. This array of tools allows us to access the point of interest from either the right or the left side, although accessing the conduction system from the left side is far easier. The PSA itself, a few words of caution: if you do have an EP system, it's much better to be using the EP system, as it's much more visually easy to identify the His lead and the His bundle. If you do not, then a patient analyzer is sufficient. You need to program the atrial channel. You need to turn the gain settings to the lowest gain so as to be most sensitive to identify the His spikes. And you need to have a sweep speed of at least 50 millimeters per second, ideally 100 millimeters per second, so as to visualize the atrial, the ventricular, and the His complexes properly as you're even trying to identify it. Also note that when you're deploying this lead needs to be measured in unipolar configurations, because the distal screw of the lead is the helix, is the cathode. So we tend to measure this in a unipolar configuration with the black on the tip and the red of the anode attached to the pocket itself. And even as you advance the catheter, the lead tip is just outside, and as it makes contact through a blood film onto the area of interest, you should be able to see the His spike coming through. So how does it look in the real world? This is on an EP system, and the sweep speed is 100 millimeters per second. So you have everything nicely discerned. You do actually have the A wave, you have the His, and then you have the ventricular channels. And the key measurement here is the HB interval, which is really important. Having identified the His bundle, all you do is you deploy the helix of the lead itself, the Select Secure, and you do that by a clockwise turn on the Select Secure lead, so as to get the helix embedded in the ventricular, in the His bundle itself. In doing so, you can often spot an injury current, as you would with most active leads. And what you tend to do is measure the HV interval and the interval between the H, or the His spike, and the end of the QRS complex. So this is a radiographic illustration of where you might find the His, and this is a proximal His. This is the distal His. This is a rather arbitrary geographical location for the His bundle, but very much in real world is about where your His spike is, how good the injury current is, and most importantly, what your thresholds are like. So we would accept anywhere the proximal or the distal His, depending on what it's sensing and how well you can capture the His. Obviously, when you talk about His capture, you can have selective versus non-selective capture. When we talk about selective capture, we are talking about purely recruiting the conduction system, i.e. the His bundle, and thereon the His bundle sending through the signal along the conduction system of the heart, generating nice narrow physiological QRS complexes. We know this is physiological when the HV interval remains unchanged, but also you have an isoelectric line between your H spike and the onset of your QRS complex. When you have non-selective His bundle capture, you tend to have what looks like a pseudo-delta wave or local myocardium being recruited. Often we notice that if you're right on the His, then higher thresholds cause non-selective capture, thereby going past the His and recruiting local myocardium. And if you're around the His, higher thresholds tend to cause selective His capture and lower thresholds non-selective. The reality, of course, is that we would accept one or the other, as there's no clinical evidence to suggest one is better than the other. There are certain concerns with His, of course. The higher pacing thresholds mean that this might, in younger patients, that might not be quite suitable. You have to program an adequate safety margin to ensure that you're getting His capture and not simply capturing the septal myocardium. You do have lower R wave amplitudes, and there is always the concern of over and under sensing, particularly when you use devices that are not earmarked for Hisses. So the fact that the His bundle is very in close proximity to the atrium means you can oversense the atria and often undersense the ventricles, particularly ventricular ectopics. And this can often be a consideration when you program the sensitivities, particularly if you haven't got a good enough His wave. You also have the worry of distal conduction block, which is essentially you're recruiting the His, but you've got no further conduction down that. And that can be a problem occasionally. There is an increased need for lead revision for all these reasons. And of course, there is always the concern of recurrent box changes or more frequent box changes in a particularly younger population, resulting comorbidity resulting from more procedures. These concerns with the His bundle have explored other options for conduction system pacing, and that is the left bundle branch pacing, which has emerged as an alternative for delivering physiological pacing to achieve electrical synchrony of the left ventricle, particularly in patients with infranodal AV block and left bundle branch block. So what does left bundle branch pacing entail? Well, left bundle branch pacing entails the placement of the lead approximately 1 to 1.5 centimeters distal to the His site in the RV septum. As the lead advances into the RV septum, we note that the notch in V1 progresses beyond, upward, and further distal, thereby across the nadir, causing an R prime wave in V1. We also note that the unipolar impedance increases from around the 300 ohm mark to greater than a 500 ohm mark. And finally, you note change in the lead position radiographically. It's what's called the fulcrum sign on fluoroscopy that demonstrates the hinge point at which the lead enters the RV septum. There are definite advantages of this because you're not targeting a specific spot in the conduction system, or rather a wider area. You're more likely to get success with this. The larger area of capture makes pacing, left bundle branch pacing a bit easier. It has a higher success in left bundle branch correction and better and more stable thresholds than the His bundle pacing. On average, thresholds you can expect with left bundle branch pacing are sub 1, whereas with His bundle pacing, you're expecting anything under 2, 2.5 is perfectly acceptable. Because it's more likely to reliably capture, there's no need for backup pacing, and indeed there's no risk with an AV node ablation. There are, however, certain disadvantages. I think successful conduction capture is rather difficult to demonstrate. And we talk about ectopics, we talk about the R prime sign or the moving of the notch, we talk about the drop in impedance. There is also the risk of septal perforation. And often when you go past the septum and into the LV, you notice a change in impedance as well as a change in electrical parameters. And when that does happen, all you can do is take the lead back and start again. There are problems with septal scar or marked left ventricular hypertrophy. And like everything, there are no long-term results. There is often the worry that the tip of the His bundle lead or the left bundle branch lead is in the left ventricle, i.e. in the systemic myocardium. And there is the theoretic risk of thrombi and very much the same risk that we talked about with endocardial pacing, thrombi and the risk of embolization. We talked about right bundle branch injury. We talked about lead position. The lead position is I would say, tentative. There is a risk of dislodgement if there's too little slack, and there is a risk of perforation, as I've just mentioned, going through the septum if there's too much slack. There is the obvious worry about coronary artery injuries with the septal perforators quite close indeed to where the lead tip of the helix touches upon. The big worry is extraction, particularly if the tip of the lead is in the systemic ventricle, and the fact that long-term data is unavailable. So coming up to my last slide, so what? I think the case is being made on a day-by-day basis about physiological and pacing. I think RV pacing, we all know and accept is detrimental to patients, particularly if you're going to be pacing more than 20% of the time. You can prevent dyssynchrony and subsequent LV dysfunction. You can restore conduction in diseased His-Purkinje systems with physiological pacing. The fact that they have higher thresholds, they need more lead revisions. There is the obvious problems of ventricular undersensing and atrial oversensing remain a problem with His leads. And the fact that this is very early days remains an issue. Nevertheless, there are some recommendations that the new era guidelines have incorporated this. They recommend His bundle pacing be considered where a CS lead has been unsuccessful, particularly when alongside other techniques such as surgical epicardial lead placement. They also suggest that if you're implanting a His lead, you should consider a right ventricular backup lead for specific situations. Thank you.
Thanks, Dr. Archana. We'll move on to the next talk by Vikram Vignesh and then have the discussion towards the end.
Good morning, everyone. I'll be speaking on value of remote monitoring of cardiac implantable electronic devices in the present COVID era. So the goal of COVID era CAD care is to offer quality services not only for the patients who are suffering from COVID, but also for the patients who have been implanted on CAD devices without compromising the safety of physicians, nurses, and the other allied care workers employed. What we are seeing all across is there is an increase in the number of implants that is happening over the years, but the clinical capacity to manage these patients have not increased concurrently. Because of these reasons, and also due to the pandemic and the fear of infection from the patient to the healthcare workers, there is an interest in the remote monitoring during the present times. So first of all, what is remote monitoring? Remote monitoring is a method of communication of information contained in the patient's device, that is CAD, and the physician who is taking care of the patient. So how do this communication happens? Usually, there is a low radio frequency transmitter circuitry that is integrated in the pulse generator. Through this, the data is transmitted wirelessly to a trans receiver. From the trans receiver, the data is transmitted through a 3G network or a 2G network or through a dedicated landline cable. From there, it goes to the dedicated server. From the dedicated server, the data is analyzed and it is sent to the physician who analyzes, and depending upon the nature of the alert or the arrhythmia diagnostics, the physician takes the decision whether to call the patient or to pass it off as a routine device feature. There are several remote monitoring system available. One such monitoring system of Biotronic is called as home monitoring, which usually sends the data every day, and also it can also be sent through the patient triggered alert. Here, between the device and the central place where the device is processed, we have a trans receiver. This trans receiver should be usually kept by the side of the patient during the night, which automatically takes the receives the data from the patient's device, and it transmits the data to the central processing unit. There are some device remote monitoring system where there is no trans receiver that is required. The device itself can directly communicate with the smartphone app, and it can transmit the data. Every single pacemaker on CRTD ICD companies have an individual remote monitoring system by various names such as home monitoring, CareLink, Merlink, etc. The working of these devices differ from individual vendor to vendor. Some transmit data daily, some transmit data every 3 hourly, and some of these devices send a periodic real-time EGMs, some send a stored EGMs, and when we see this, there are several other features, important features such as heart failure sensor. This also varies from vendor to vendor. That is, one sees the heart rate variability, other sees the thoracic impedance, and other has a separate, the Sorin group has a separate diagnostic feature called sonar, which helps in early identification of the heart failure patients. So what are the data that a physician gets to see in a remote monitoring system? Apart from the routine parameters such as sensing and impedance trends, the battery status, the physician can also see the therapies, that is ATP therapy or a shock therapy, and can decide whether this is an inappropriate or an appropriate therapy. And also he can see the stored EGM and also the real-time EGM that was taken during the transmission of the data. Apart from this, the various arrhythmias, that is atrial fibrillation onset and the duration, ventricular arrhythmias, and also the heart rate variability can also be accessed through the remote monitoring system. The specialized heart failure algorithms consisting of various features, importantly, the thoracic impedance, which usually decreases during the episode of heart failure, can also be seen and used to predict the onset of heart failure in these patients who have undergone CAEDs. As I said earlier, a composite score can also be used to predict the onset of heart failure. The composite score has several features such as AF duration, ventricular rate during atrial fibrillation, the fluid index, the patient activity, night heart rate variability. All this can be put into a composite index which can be used to predict the onset of heart failure. So how does the remote monitoring data looks like? There will be initially a summary page consisting of the essential device parameters and the stored EEG, and also the diagnostic summary consisting of arrhythmia events, the arrhythmia episode summary, what the device has classified the arrhythmia as, what it has done to the arrhythmia, how it has treated the arrhythmia, and the EEGs to support any alert. So we kind of basically get all this information to analyze. So what is the advantage of this remote monitoring system over conventional in-hospital visit of the patient? One, it leads to significant reduction in clinical evaluation, saving the physician time. It also helps in early detection of the heart failure and also the prevention of stroke because of the early detection of the atrial fibrillation. And also what it leads to is adherence to the medical therapy or conventional care is more in patients who adhere to the remote monitoring system. Of all these features, the remote monitoring has led to over many trials. What it has shown is there is almost 50% reduction in mortality over 5 years for ICDs and CRTDs. Same happens with pacemaker also. Not only the reduction in mortality, about 35% of the reduction in cardiac or device-related emergency department or urgent inofficial visits are also reduced because of this remote monitoring system. As I said earlier, whenever we use the composite risk score to predict the heart failure, this has a predictive accuracy of 5.5-fold increase in the risk whenever the parameter is above the set cutoff time. So what is the HRS is advocating? In 2015, they came up with a consensus statement recommending to use CAD in all patients who are undergoing implantation, and the CAD should be implanted as early as 2 weeks within the implantation. So the remote monitoring system should also be used to for the surveillance of the leads, and also to reduce the incidence of the inappropriate shocks and early detection and quantification of the atrial fibrillation. All these have been given the highest class of recommendation by the HRS. So with the onset of the pandemic, the HRS has come up with some more advice for the CAED implant management. That is, the initiation of the remote monitoring should be at the time of implantation, and it should not be delayed any further. And more so, the patients who are not enrolled in this remote monitoring program should be enrolled in this program to offer further care. All these patients should be monitored strictly with remote monitoring, and these in-clinic visits should be avoided unless there is a urgent alert, or there is a symptom such as syncope due to arrhythmia, or a device or a lead malfunction, or a suspected device infection, or an incessant arrhythmia. If none of these reasons are there, then we shouldn't call these patients to for the in-clinic visits. We should rather manage them with remote monitoring system. These patients, especially for a routine device checkup or an interrogation or an MRI planning or a perioperative mode switch or a CRT optimization, arrhythmia burden assessments, these are the for these reasons, these patients should never be called for an in-office visit. What has changed during this COVID time? This is a large EHRS survey which has shown that with the onset of COVID, the percentage of the implanted patients who are taking this remote monitoring system have tremendously increased. But what should also be noticed is, even in the Western countries, the percentage of the people who are using remote monitoring is subpar, and it is nowhere near to even 80% of the total implants. How frequent were the in-person visit during this COVID period? What we have seen is the number of months for every visit has increased during this COVID era compared to the pre-COVID period. But with tremendous amount of the data and scarcity of resources, importantly, the healthcare professionals who managed these data, who examined these data, if we see in the Western setup, it is always a specialized nurse, that is device clinic staff or a physician assistant, who took the majority of the responsibility in sorting out these alerts or the routine device data analysis, followed by the doctor. But in India, we do not have a lot of trained device clinic nurse, so everything will fall on the doctor for the management of these data that we receive. What are the main reasons during this period? More or less, what we see is the reason for calling these patients during inpatient visit are same as before, like sensing or a pacing issue, or a lead malfunction, or a ventricular or atrial arrhythmia events. But what is the reason for underutilization of the remote monitoring for the COVID era is the most important reason was the lack of reimbursement by the insurance company and the lack of people who are managing these devices. These are the two principal causes for underutilization of the remote monitoring during the COVID era. One more important thing that COVID causes is, apart from the inherent risk of integrating these patients. COVID per se causes hypoxia, myocarditis, myocardial ischemia. All these led to increase in arrhythmia burden. So these things should also be kept in mind while managing these patients. I'll show some of the real life examples of this. Is a patient who recently underwent CRTD, that is in the September 2020. So the initial pacing burden, the pacing percentage was 99%. On a subsequent remote monitoring, what we found was the ventricular pacing percentage was only 44%. So what could have been the reason for the sudden decrease in the BIV pacing percentage? When we looked at the real-time egram of these of this patient's device, what we found was atrial sensing and the ventricular sensing happening simultaneously for this patient. So what could be the reason for the atrial sense and the ventricular sense to occur simultaneously? So we called this patient and we did a thorough interrogation, including the fluoroscopy. What we found was the atrial lead has fallen into the ventricle. So that has led to the atrium and ventricle simultaneously sensing the ventricular event. So this patient underwent the atrial lead repositioning during this COVID time. And following that, you can see the atrial sense followed by the biventricular pace, which should occur for a CRTD is occurring in this patient. And this is another example where the patient had a shock syncope due to VF and a shock, and because of the egrams that we were able to access, what you see is a very fast heart rate, more than 230 to 40 per minute, which the device has appropriately tagged as VF, and it has given a shock. So this was an appropriate shock, and the patient was managed in a far off place with an antiarrhythmics. So this is one another patient who underwent ICD implantation. Initially, the patient also had an on and off AF, but the patient's symptom dramatically worsened. When we analyzed the remote monitoring system, what we found was the AF, which was well controlled initially, the burden increased subsequently, leading to very high AF burden. And we called this patient, and we subsequently did ablation for the atrial fibrillation. Then the remote monitoring helped to overcome all these features. So to conclude, remote monitoring of CAED is the standard of care and should be advised to all patients immediately after device implantation. It has survival advantage and importantly reduce the hospital visits during this COVID time. Remote monitoring will definitely allow the physician and the patient connection to be maintained. The barriers to the successful implementation of the remote monitoring in our system should be well studied and it should be immediately addressed. Thank you.
Thanks, Dr. Vikram. I think that was wonderful in the current pandemic situation to hear from you. We'll move on to Guru's talk on troubleshooting of devices at follow-up, followed by the LA appendage closure, and then we'll have the discussion.
Hi, good afternoon, everybody. I thank you, TNEPIC, for the opportunity of delivering my lecture on device troubleshooting. So I want to discuss about case-based scenarios on this topic. So here is the patient of dual chamber pacemaker implantation showing the AGMs and what could be the cause of double counting of this atrial channel. So you can observe carefully that so for 2 atrial counts, only 1 ventricular beat is there. What could be the cause of these high atrial rate episodes? So this is simply because that, so if you observe carefully, it is after the ventricular ACM. That means it could possibly be the far field or wave sensing. Especially this will happen when you program the leads to unipolar sensing, and if the leads are very close, like atrial appendage and outflow tract leads, and especially if your sensitivity thresholds are, if you have set it very high. So this is far field or wave sensing that can be avoided by programming sensitivity to a lower level and configuring the leads to bipolar sensing. And here is a elderly lady post VDD pacemaker implant. And whenever she carries weights in the left hand, that is on the implant side, she feels giddy and breathless. So what could be the cause? So again, this is a sensitivity issue. You can see that. So myopotential sensing, over sensing, and leading to inhibition of the pacemaker, causing symptoms. So again, this could be due to high sensitivity thresholds and unipolar programming. So that can be avoided, changing it to bipolar programming and sensitivity keeping less. So one more DTD implant pacemaker while doing exercise, that is ergometry, handheld ergometry bicycle test. And here is what happening. Suddenly, they started feeling some skipped beats. So atrial ECM is pretty regular and faster, and you can see ventricular beat, every fourth beat is dropped. So this is the classical upper rate behavior of the pacemaker. If you clearly see that the upper tracking rate is only 120, and definitely the heart rate, atrial rate is above that. So leading to upper rate behavior of the pacemaker, that means leading to 4 to 3 conduction, every fourth beat is dropped. This is a normal behavior of the pacemaker. And another patient, another DDD implant. So here is the tracing, what is happening. So definitely you can see pacemaker spikes and absent pacemaker spikes, and there is something happening here. So the first 3 beats are ascens, VP, and the first 2 beats, the third beat is A pace, V pace, and definitely you see the fourth beat A pacing, but atrium is under sense, that is not sensed. Immediately after A pacing, you see intrinsic beat followed by a ventricular pacing spike. This is classical ventricular safety pacing feature of the dual chamber modes. So these are the important findings here. Here is maybe ascens, V-sense. Again, ventricular safety pacing here. Remember, ventricular safety pacing happens only after atrial pacing, not during atrial sensing mode. So this is to avoid, this is to ensure that ventricle is 100% paced, especially in ventricular pacing dependence. So this is about ventricular safety pacing. So once it paces the atrium, as soon as it senses little in ventricular channel, it ensures that ventricle is being paced. So another patient, so atrial channel, ventricular channel, and annotation. So what is the pacing mode? As soon as you see APVP, it means that it is a dual chamber pacing mode. But once both chambers are paced, so and both chambers are sensed, so two letters are over in the triple code. So next is IRD. So remember, if any drops, if atrial drops are there in dual chamber pacing mode, if any atrial beats that are dropped, that means it is in the inhibition mode, but not in the tracking mode. So it is a DDI mode. So if both chambers are pacing, it is dual chamber mode. And if there is a lack of atrial tracking, that means it is the inhibitory mode. So another patient. So this is definitely atrial fibrillation, not sensed, paced but not captured. So this is a typical example of undersensing and non-capture. So this is a single chamber VVI mode, and this happens after a few years or some time after implant. Classical subclavian crush syndrome, you can see that in X-ray. So you cannot capture. So this is an emergency. You need to redo and reinsert the lead and then check the device. Another patient post device implant, and the monitor next down the monitor. and sister says me that, sir, pacemaker is not working properly. Some beats are missed. So do you really think so? Actually, this is a normal behavior of the dual chamber pacemaker. A sense V pace, A sense V pace. But when the rate competes, you may find the normal beat, captured beat, and especially because it is refractory, you may not capture the ventricle. And this is normal sensing mode, A sense, V sense mode. So it is normal behavior of the dual chamber pacemaker. And another patient, the dual chamber pacemaker, you see patient has developed so some palpitations and device interrogation showed tachycardia. You can see the onset, so something is sensed over in the atrial channel after the ventricular pacing. Okay, and this is a classical endless loop tachycardia, that is pacemaker reentrant tachycardia, so which is iatrogenic circus loop tachycardia. So especially the retrograde. So this means that there are prerequisites for this endless loop tachycardia. So it must be dual chamber pacemaker. There should be retrograde VA conduction, and the retrograde VA, that is retrogradely sensed atrial wave, should fall beyond the ventricular refractory, that is PVAR, and that will track down and initiate the tachycardia. So the best way is immediately to apply the magnet and maybe set the you can make it to auto PVAP mode, and maybe or just extend the PVAP values. Okay, so another patient. So patient was implanted somewhere the dual chamber pacemaker. He came to me with repeated episodes of palpitations, and the device interrogation showed so rapid conduction, that is fast atrial fibrillation with fast ventricular rate of the atrial channel. And because because of the upper tracking rate, patient has sometimes rapid conduction, so and repeated symptoms patient used to have, and patient has also symptoms of TIS because of atrial fibrillation. So what I did was, because already device was implanted, I knocked off the AV nodal ablation, and I started him on adequate doses of amiodarone and beta blocker, and also on Novax. So you can see that ventricular rate is fixed. This is because no more tracking of the atrial arrhythmias to the ventricle after AV nodal ablation. So this is one more patient of dual chamber episodic palpitations. So what is happening here? What is the diagnosis? What is the arrhythmia? You can see the enlarged mode, ascens, VP, ascens, VP, ascens, VP, ascens, VPACE, and there is something happen here. So this is atrial ectopy conducted to ventricle, and an echo leading to prolonged PR or AH interval. This is a classical AVNR. Simply, you can see that prolonged PR initiating AVNRT. Okay, and the pacing terminated the tachycardia. So it is possible that device patients will also have other arrhythmias like AVNRTs. So this patient can undergo easily the EP study and RF ablation. This is an ICD implant patient 3 years ago. Multiple shocks. So what could be the reason? You can see that a lot of noise. Please remember, especially a lot of noise. This is a single chamber ICD. A lot of noise leading to shocks. So check the lead integrity. Probably there will be device that means it is an open circuit. So lead might have fractured. So this is earlier leads, which especially Fidelis lead, which were recalled later. So this is one more patient of ARVD post ICD implant received multiple shocks. What could be the cause? You can see this is a EGM. So tall T waves. Okay, so this is T wave overcounting. So every normal complex T wave is overcounted, and the device interprets it as fast tachycardia, thinking it as ventricular tachycardia, leading to inappropriate shock. So there is a beautiful program parameters that can be adjusted. So because thresholds are difficult, sometimes see that there is what is known as delay decay. Okay, for immediately after sensing the ventricular region for certain times, it becomes flat and then starts sending is the beautiful parameter that can be adjustable. So avoiding these inappropriate sensing. So this is one of the non-responder of the CRT patient. And after implants of a few months, again started having breathless. And what is happening here? You can see that, so as soon as atrium is sensed, the ventricles are paced. There is no adequate AV delay. So it's only the diastolic period during which ventricle can fill. So programming adequate or optimal AV delay is very vital in to make CRT implantation to give best results. Okay, so this is inappropriate AV delay programming leading to CRT non-response. This has been corrected after adjusting the AV delay. So one more patient of CRT. The LV lead is actually in the anterior, that's cardiac vein. And he's also one of the non-responder. What is happening? And this is the ECU. You see A sense, RV pace, but LV is only sensing, not pacing. So because LV is not paced, so his ejection fraction did not improve and he started having symptoms again. So this is possible whenever LV is retracted back to CS, or if you keep the basal lead electrodes as sensor and pacing electrodes. So especially that will sense the atrial wave, far field atrial sensing. That is the mechanism. That is why LV is not paced. So once you make the distal LV tip, so as the pacer, so this is non-response due to far field, atrial sensing. So if you program the LV lead tip to RV lead, then patient will respond well. So these are about some of the device interrogations where we need to interpret carefully. It's not only how best we implant, is also how to interrogate, and we should know how to program the device, how to, after encountering the difficult situations and device troubles, we should be thorough in handling these problems carefully. Thank you very much.
Thanks, Guru. I think we should move on to Dr. Ranjan Shetty's talk on the LA appendage closure. Kindly put up his presentation.
Thank you, TN Intervention Council, for inviting me for this talk, and I'll be happy to give a talk on left atrial appendage closure tips and tricks. We know that AF is a very, very common problem. It is a population disease. As people become aged, more and more people will have AF. The biggest problem of AF is stroke. More than irregular pulse, it is stroke. And stroke due to AF is much more severe, much more dangerous, and it leads to death and disability in a large number of patients. The treatment is obviously oral anticoagulation, which is available for anybody with high CHA2DS2-VASc score. Now we also have novel anticoagulant drugs which are available. But the very patient who is likely to have stroke is also the patient who is likely to bleed. So many of our patients do not receive anticoagulation, and even when they receive, they don't receive in an optimal dosage. So there is definitely a need for alternative because not many patients are on therapeutic window. There are people who have CKD, CLD, uncontrolled blood pressure, neurological diseases which make them, fall, and where they just can't tolerate. And also there is a residual risk of 2 to 5% which occurs on anticoagulation stroke. So these are some of the people who are very good candidates for this therapy. Drug therapy, although is quite effective, but people are not very compliant, and with time to come, many of the people even stop drugs like statin. So it's obvious that dangers like warfarin are stopped, and we won't even know that they have stopped. Now, the rationale for alternative is that in non-valvular AF, that means AF not because of moderate severe MS or a prosthetic valve. All other AFs are called non-valvular, which includes HOCM AF, which includes MRAF, and which includes ASARAF. So these patients, the majority of the clot, which is more than 90 to 95%, actually is in appendage. So if you can close it very safely, it could work well, and that's the rationale for alternative. Now the worry for most interventionists is, in coronary you could choose type A lesion and start your practice. You won't be able to do it here because anatomy is highly variable. So a reasonable skill level is needed before you start your cases. We do name left atrial appendage in whatever food we have had or whatever the food we like, but to be honest, individually speaking, each appendage is very, very specific and very different, and it's something which needs to be closed. Now, how do we do it and what do we do? Typically, it is done under transesophageal guidance. You may not do it under general anesthesia. In our center, most of the time we do it under local anesthesia. We need to be little familiar with anatomy. It's a 2% job and we should know. Now, appendage has to be visualized in different views. So typically we have to visualize in 0, 45, 90, and 130. We don't need to do any pre-transesophageal echo. The transesophageal echo can be done on table. That's how I do most of my cases, except wherever I go to proctor, I request my colleagues to just do a transesophageal echo to rule out clot. The sizing decision is done on table most of the time. To size, the most important structure is probably circumflex. So at the level of circumflex, if you draw a horizontal line, that's where the device lands, but you have different numbers which you get for Watchman device and different for Lambre and ACP and other devices. We should also realize that left atrial appendage has two axes. One is axis of the neck and second is axis of the body. So there are devices like Amulet, ACP, Lambre, which actually cover the axis of the neck, and Watchman is the device which covers the axis of body. So at level of circumflex, you measure. If you want to use a neck-based devices, the measurement would be something like this. And if you want to use the body-based device, this is how the measurement takes. So you measure it in multiple views, upsize the device by 2 to 3 millimeter. Too much upsize may not work. So in this case, this is how the appendage looks. So if you're using Watchman, this is how you measure. If you're using ACP Amulet, the measurement would be somewhere here. And for Watchman, you upsize by 3 to 4 millimeter or maybe more, whereas for ACP Amulet you upsize by 2 to 3 millimeter. So there are device specific cutoffs. So it's advised that when you start your practice, you try to do it with one device, understand the left atrial appendage anatomy and understand the appendage, and then shift to this. Today I'll be describing the procedure using Amulet device, which is now it's even FDA approved for LA closure. It has CE mark for a long time. So you realize this device sits at the neck. It has two parts. It has lobule and it has disc and it has multiple hooks. Practically almost all atrial appendage device actually have hooks, and that's how it works. So if you see here, you realize that this is the device which is actually in the neck and multiple hooks are protruded, and the way it holds itself is more like pacifier. It's difficult for the child to pull out its pacifier because more you pull it, it actually gets stuck. So this is how it turns. So there are double protection which comes, and there are radiopic marker in the device which can be used, and you can make it a gola that makes it very safe, and when you go in and out of the appendage, it is quite safe when you do this. And with time, by 45 to 50 days, actually the device gets endothelized. This is a picture animal model which shows the importance of circumflex in understanding the neck of left atrial appendage and how it endothelizes and how the device positions itself. Comes in different sizes from 16 to 34. Typically, as I was repeating, we upsize by 2 to 3 millimeter. When you finally deploy, it should look like this. This should be compressed, and the neck, there should be a good separation between disc and neck. Should not be flat like this, which is undersized, sign of undersized. Should not be entrapped. This is called a strawberry shaped. Very rarely you'll have to accept strawberry, but it's not the best of the sizes because hooks are not fully extended. The best size will be tired shaped, good separation, most of the device within the circumflex, and the disc beautifully covering the neck of the appendage. So I'll describe a case. This is a 78-year-old male, diabetic, has anteroseptal MI, CKD AF, recurrent syncope, intracranial bleed with OAC. So this patient has no other option but to undergo atrial the LA closure. So this is very important. The first two frames actually showing transesophageal echo, and this is the bicaval view where we are going to do a septal puncture. In this case, what we want to do is the septal puncture, we want it to be done just below at the lower part of the soft septum. So if you see the septum, there is a thick part and a thin part. We don't want to be in the thick part. We want to be in the lower part of the thin part. So the puncture has to be inferior in bicaval view, and in iotic view, by rotating the broken barrow needle clockwise, you will go posterior. So puncture has to be posterior inferior so that it's easy for you to go in this. So in our center, we do under local anesthesia with Dexmed, and the septal puncture is done in AP view. 50% of the heparin is even given before you do. So the puncture, although you're doing the puncture under fluoro, it is completely TE guided. And then you image. Most of the time, once you do the puncture, you measure the LA pressure. The LA pressure is less than 10. You need to hydrate to get it up. And then the TE is already done. The clots are ruled out, and then you start measurement. You request your echocardiographer to measure in 0, 45, 90, and 135. Ask them to give a number. This number, which is around 10 millimeter inside the ostium, you upsize by 2 to 3. So here in the lower frame, our sheath is already in the left pulmonary vein, and we are taking the device in amulet in this case, and as you take it up, you see a gola. But again, you can clearly see that it is both echo and TE based. From the appendage, you could be in upper pulmonary vein when you are exchanging. After that, the device with the gola is completely pulled down, and as you pull down, if you see here, we are pulling it down. It falls to LA, and then when you push it, it enters appendage. So you can see it also in TE as well as in echo. So you pull the whole system down and you bring it down. So in this figure, you see that the device is now already in the appendage, and you are trying to do an anti-clockwise tilt. More anti-clockwise you do, better it is, and you start unsheathing. You don't unscrew it. You unsheath it. You keep looking at the echo. You keep looking at the fluoro, and it is done in RAO cranial view. You don't need to do angio for this. You know where you are. As you unsheath, you realize the appendage starts opening up here, and you get a triangle. From gola, it becomes triangle, and then the lobule is completely out now, and you need to look at the echo to make sure you're in the position which you want. If you're not happy with this position, you could recapture, go little in or little out, maintain the anti-clockwise torque, and unsheath. So that's how you do. As you do more, you realize that with the unclogs, if you see the down one, you realize with the unclog, you are also seeing here, the disc is released, and disc is now covering the ostium. All this needs to be confirmed with the echo all the time, live echo. And here, once we remember that the disc is now expanded and the lobule is compressed, we call it tire shape. There is good separation between lobule and disc. And see here, we are doing a wiggle, a slight wiggle, a constant pressure, not really like the ASD wiggle. It's much milder, a slight wiggle to make sure that the lobule is not moving independent of the appendage, and the disc can move and cover. So once you are happy with this, you ask your echocardiographer to recheck the position, and you make sure that your wiggle is fine, the compression is good, there is good separation, and most of your device, at least 2/3 to 3/4 of your device actually is within a circumflex, and you decrease the gain and make sure there is no much leak across the device, and you're happy with the position. At this time, you can unscrew. It's a simple manual unscrew which you do with your hand and release the device. So if you see in this picture, because the patient had CKD, we did with zero contrast. You don't need contrast at all because most of these are guided. But since most of us are intervention cardiologists, we tend to do angio. If you want, you could take 2 angios, one in the beginning with the pigtail or with the sheath, just to profile the appendage, which is typically done in RAO cranial view for neck-based device, and for Watchman, it is done in RAO caudal view, and one at the end to make sure there is no peri-device leak and there is no structure here. And this is how it looks in echo. If you see the device, lobule is beautifully positioned, circumflex is somewhere here, and the disc is covering the ostium, and that is what you see here. The upper pulmonary vein flow is good, and when it endothelizes, it's going to be fine. At this, once you are done, you pull the sheath back. Since it's just a venous puncture, we don't do any arterial puncture. You could take a figure of 8 and close it off. So this is how we typically do the procedure, and most procedures are pretty simple if you are systematic and if you respect left atrial appendage. One important point is never be too pushy in the appendage. It's a very thin structure, so never push your sheath inside. If you want to go in and out, only 2 things you could do. You could use the pigtail to lead your sheath to go in and out, or you could, in case of amulet and SAP, you could also make the goal of the device and slightly take it in. Like any procedure, complications are possible. You have to be careful about air embolism, bleeding. Probably the most common complication is pericardial effusion, but if you're delicate on pericardium, if you have done each of your steps carefully, then the chances are less. Embolization is not very common, and it happens with ACP amulet if you oversize it too much. Only then it embolizes. Otherwise, it's not much, but it's a soft device. If needed, we could pull it back. So thank you for patient hearing, and I'll be happy to take questions if there are any. Thank you.
Thanks, Dr. Ranjan. The floor is open for discussion. Doctors Ram Prakash, Shanmu Sundaram, Dr. Kannan sir, Dr. Archana is there with us. We can ask her questions related to this. So maybe I can get started by asking Dr. Archana, is LA appendage closure fancied stuff now? Because when I was back there, I didn't see much of it happening then.
Yeah, like most things in the NHS, it's all about funding. Okay. We certainly do them, but very much for the indications that were just mentioned by the speaker, the preceding speaker. So where there are distinct, where the Chad's VAS risk is high enough and there are distinct contraindications to DOAC, that's pretty much where we tend to offer them. Again, we've been offering them under local anesthetic. I mean, I don't personally implant these. My interventional colleagues and my AF ablation colleagues tend to do them. But yeah, it's very much a done thing. And there's often a niche group of patients who would definitely benefit from it.
Welcome, Shanmu Sundaram. You should be asking questions because a lot of work you do is sort of what Dr. Archie also does. So please go ahead.
Good evening. This is Dr. Shanmu Sundaram from Madurai, ma'am. So it's just a wonderful presentation on conduction system pacing. So just wondering to get some opinion regarding non-3830 leads for horizontal pacing as well as lateral pacing. Your experience about non-3830 leads for lateral pacing.
So I've not actually, that's a really good question. I haven't actually used the non-3830 leads at all. And I must confess that when you look at how far in the screw needs to go to actually capture the left bundle, I'm not sure the screw length would be adequate on the normal helix. So with the 3830, the helix is almost 1.8, almost between 12 and 14 millimeters. And I think to actually access the left bundle, you need to get about 11, 12 millimeters further in from the His. The recommended manufacturer recommendation is 4 to 6 clockwise for the select secure for the 3830s. But really, to get adequate left bundle capture, you're doing between 10, 12, 14 turns. So I would say that would be my one reservation, accepting what you're saying, that if you had a stiletto, you would probably be able to direct the lead much more easily. And I guess that the manufacturers have seen it, which is why the newer sheath in the older version is very much a deflectable sheath with a larger primary curve. The sheets are available in a few curves, but that would be my experience. But a lot of you have a lot of experience with bundle branch pacing, so I'd be keen to hear what you guys do. And have you got much experience with a lumen lead, a non-select secure lead on bundle branch or His bundle pacing? Because we don't. I certainly don't.
Just the same thing which you have experienced. So we have done quite good number of cases of lemon branch pacing, but all of them on 3830 leads. Unfortunately, I didn't have the provision of getting other leads also for just testing it how it works. But there are a lot of issues regarding this stiletto-driven leads. So one thing is that whatever sheet they are providing is really good. I've heard that it's much better than the C315 sheet. We have only C315. We don't have a deflectable sheet. But the C315 solves the problem in many of the cases. This 4.1 front size lumenless lead works. What I feel is it works much better as compared to this stiletto-driven lead. The problem with the stiletto-driven lead is one thing is that it is a bulky lead. You cannot do multiple attempts. I'm a guy who can go for at least 7 or 8 attempts if I'm not able to get a good position. So that multiple attempts may not be possible with a bulky 6 French stiletto-driven leads. And another thing is that I've seen a couple of case reports 2 years back itself regarding this helix breakage. So at least 2 cases were reported in last year's JC where the helix got broken, and I've heard some 2-3 inputs from Indian operators also that in some of their cases, while repositioning the lead, the helix got broken and they had to leave the helix within the septum. That is one major concern regarding this stiletto-driven leads. But as such, the sheet gives better support. But the lead, I think it's still, we are in the evolution stage where probably the future will be getting good sheets, lead.
I agree completely.
I think if there's no more questions, we should wind up this session. Thanks all for joining. I believe Dr. Archie has to sign off. Thank you very much for being here with us and enlightening us. It was wonderful having you with us. Next time, probably in-person meet we'll organize and surely have you in Chennai and probably do some cases.
We certainly hope so. Yeah. Thank you, guys. I'll try and join the next session. I've just got another meeting, but I'll jump back in.
Oh yeah, that's good. We'd love you to be around. So